When's FMA coming up?
Like right now.
Back in like November.
No, well, Cameron literally texted me like yesterday.
We had the same conversation in November.
Oh wait, let's do this before.
January.
Yeah.
Let's just do this real quick before we do this call. This is gonna be worth it.
Hello?
Yo, C.
Yo, what's up, Dr. N? How are you?
How you doing?
Hey Cameron.
چطوری بابا؟
حال شما؟
Who's that one?
It's me, it's Jaffari.
Jaffari.
Baba.
I thought it was Jawley.
Oh, Jawley is actually happens to be here as well.
Howdy.
Oh, okay.
But no, anyways, hey, I'm just calling real quick to see. It sounded like you were just waiting on really one piece for FMA, right?
Yeah. Last time I talked to you, it was pretty much ready, but then I knew if I was going to send it to you guys.
So then you got to do some feedback. So I did it myself. I just got in the system here and started trying myself. So say celery concept part.
Okay.
Like three or four things. And those are all sorted out now. And so when you get it to be ready to rock basically.
Oh, great. Okay, so you think, like, let's say if someone were to ask me, or if I were to tell the public when I'm gonna get my FMA, what should I say?
Wait, so we're recording a podcast like right now with updates, and so that's why. So when is Newaz starting his FMA?
Yeah, the FMA. That last piece that I'm waiting on, they said they're going to be shipping it today. So, I should have it, I presume, by like a week.
Nice.
And then it'll be on its way to you. And perfect. Like I said, for my testing, I personally tested it, and I'm very confident with it right now. And the best part about it, like I said, is you're not going to need that headpiece. That's the way it seems right now, and so it's super comfortable without a headpiece. Really comfortable and easy to use, and so I'm really excited about that.
Alright, so we can tell the public Newaz is starting his FMA in 2 weeks.
Yeah, totally, yeah.
Cool. Fantastic. All right, man.
Alright, Cameron, take care.
Nice to talk to everyone.
Alright, we'll talk to you soon, okay? Thank you. Welcome to the Jaw Complex. We haven't had an episode in a while, so we wanted to jump right in, go over some updates, some news, and stuff like that. I guess I could start off. I have a beautiful new baby girl that was born a couple weeks ago, so I've been on my paternity leave. Thank you to Ronnie for some of the tips and pointers. Yeah. Dr. Newaz, how you doing? How's that expansion?
Yeah, it's going great.
Let's see your smile.
Here, step up and show the camera real quick. The gaps.
Yeah, this one right here. Yeah. Awesome. Hey. So how's breathing, sleeping?
Yeah, no, breathing is nasal breathing is undefeated right now. It's been very good daytime nasal breathing, and then at night there's definitely a reduction in the snoring severity, and more things like the continuity and the depth of sleep I think are improving. I've always been a little bit of a sleep yield guy because I can't necessarily get enough uninterrupted sleep, so I find that my little windows of sleep, whether they're my nighttime abridged sleep or my power naps or whatever, I get a little more out of those now. So that's always good. A patient had described me as looking a little perkier, last weekend. I'll take that. Yeah. I mean,
Your face has changed up a little bit, right?
face has certainly changed. I think I've heard that quite a bit. For me, again, I'm very fortunate that I've been one of the more uneventful FME expansion cases. So far, mine has gone really well, really smoothly, totally painless, no resistance, no nothing.
Now, what did you do differently that you think you implemented?
Yeah, I think, for me, a big thing, as I've told a lot of my patients, is the hard clenching. trying to send, basically forces up the kind of lateral aspect of the face that will then help, transfer some of that pressure up the mid face in a region, right? The tendency of the expander, right, is to do this. So if we are, putting a lot of pressure on the lateral, then we're, helping the midfits do this in reaction to that. So it's kind of like a, moment, counter moment kind of thing.
So what are you using that like to chew, or are you using munchies or chewies or?
I'm just kind of going for it. I do chew some gum, so that's one thing, and not necessarily for the purpose of this. Just like a lot of raw, just like clenching. When I think about it, of course, more so in the beginning stages when I was starting to get, some movement. I was like, oh, it's like kind of exciting to feel like a little bit of the the sensitivity, the flexion. You can kind of see it in the mirror, and so I think that I was obviously a bit, I think of an expansion bro when it came to that, but I did it. I do think it helped. I also did some thumb pulling kind of stuff. I would kind of massage.
So how long would you be doing that thumb pull?
Oh, maybe like 10, 15 seconds at a time.
How many times a day?
Just here and there. Maybe it ended up being like, I don't know, 3 to 5 times a day. I kind of, and of course, these days it's now few and far between. I'm pretty much
Are you going to change the expander body up?
I think that's TBD. I think kind of what I've been, telling myself and others is that once I max this one out, I think I'm 8 and change at this point. Once I max this 9mm expander out, we'll take a scan.
So also, are you turning my
Look, maybe like a couple, like I usually make a couple cranks at a time, and now they're spaced out like 2-3 weeks apart. I mean, I just like literally when I remember and I see a wrench and it's like, oh, it's been 2 weeks. I'll give it a couple.
Wow, 2 weeks apart.
Yeah.
Wow.
Well, I think there's also a rationale behind that too right now. So the next, I guess, update is FMA.
Correct. Yeah. And so I think you hit the nail on the head with that. Of course, I'm going to be a user of the FMA, of course, Facegenics, Protraction system that's compatible with the Protraction, capable FME bodies. So I'm going to start that in about 2 weeks. I think we've got some official word now that 2 weeks later, we're going to have the opportunity to actually try it on. This thing is pretty robust looking.
Yeah.
Just between the wire apparatus that engages on the FME itself, then there's going to be kind of like a box spring cartridge type of thing. Forces will be able to be calibrated from 1 to 7 kilograms on that. And then we're going to be able to get, a chest piece. And then there's a recent modification that looks, like it's going to maybe help hold everything down, which is kind of almost like a little jock strap looking thing. Like no joke, I think that's going to be an additional component that might be part of these things if, of course, anytime we're applying this amount of force, right, the neck's going to absorb some force, all that kind of stuff, right? Of course, we want the chest and the abdomen to be able to be the primary stabilizer for this arm to be able to pull the midface out. Of course, yeah, it's going to be, I think
Better posture from that too.
Well, better posture, I think, will result if we are conscious about countering what the FMA is going to do, right? FMA is going to tend to pull the whole head forward with that amount of force. And so trying to do some McKinsey chin tucks and holding the head back and this and that, I have a feeling that, maybe working out some delts and lats and stuff like that. And, kind of, just keeping some nimbleness and flexibility with the neck, doing some neck circles, this and that. I don't know, maybe we'll refine them, with one of our, I guess people who are more, I don't even know what I'm really talking about when I talk about these kind of exercises. So I think with someone with a little more exercise IQ like you, might, be able to actually kind of come up with a little FMA regimen, like a little, FMA force absorbance workout, right? So I think that would be really cool, actually. And then we could, have it on a sheet of paper and give it out to patients who are doing protraction. It's like, hey, to get, just a little bit out of it, a little bit more out of it. And then, of course, that's a really good segue to talking about really the merits of physical therapy, myofunctional therapy, with, of course, a lot of the work that we do, just because, again, as the structure guys, right, we're usually the ones responsible for creating the real estate and making the house actually fit and engineer it to actually last. But you need basically the functional aspect, right? You have the structure, but there's no benefit really, or marginal benefit in improving structure without optimizing the function within that structure. I think this, of course, is a microcosm of that principle where, of course, for a lot of the work we do, we see that even the functional stuff alone might even outperform some of the structural stuff. What is it, 62% improvement for children on sleep disordered breathing with myofunctional therapy.
That study, we'll put a link in below of that study. The Stanford study from Dr. Camacho that shows that myofunctional therapy can reduce children's sleep apnea, AHI by 60+%, and from adults about 50%. So with that being said, we do plan in the future pretty shortly to include and have myofunctional therapy for our patients, especially post-expander patients after they've expanded. Then they can learn how to reposition their tongue, swallow, etc., with that wider palate. So we do think that, with the expansion itself, and then now with myofunctional therapy, you get better relief for sleep apnea symptoms.
Absolutely.
Before we switch gears from the FMA, I did want to talk about protraction in general.
Yes.
Obviously, what are your thoughts about that? What success have we seen so far with protraction, and then why is FMA theoretically more powerful than our current protraction type of devices?
Great question. So the whole premise of bone anchored protraction, right, for maybe later teenagers and adults, is that with sutural disruption and disarticulation, that basically the bones become receptive to traction-based force. With traction comes the opportunity for cellular neogenesis at the bone level biologically. This is a concept that is well established and documented in the medical literature. Basically, through that, process, of course, facially, how might it be able to be applied in a way that produces meaningful, clinically significant gains? It's a product of wear time, the time and the force and the consistency, and basically not letting some of the gains recoil. Of course, we can always expect a little recoil, but basically the idea is to kind of continue to allow this, stimulus, biologic stimulus through tension, help us create, a little bit of, tissue. And so when it comes to protraction, in general, right, of course, theoretically, any extraoral anchor and any, force distribution mechanism, whether it's a string and an exercise band or a rubber band or whatever it is, or in the case of FMA, which we'll talk about, like a box spring, right? It's a little cartridge with a spring in it. I think, no matter what the mechanism, or the material is, there's a way to basically apply the force to the subject bone mass, which in this case is the maxilla/midface, and basically having a way to control the vector, I think is important. Some of the more rudimentary methods of midface protraction, perhaps we don't have as much vector control. Perhaps we have a problem with reciprocal anchorage being in areas that are otherwise undesired, or whatever, right? So FMA basically seeks to be a system where your reciprocal bracing is in the chest versus the chin,
And the force.
which that's just public service announcement. We do chin cup face masks all the time. It's still kind of the standard thing I give to most children and even some adults, which of course classically my adult patients who have gotten successful protraction have used that and used it well. So it's more a matter of being able to tolerate it. There's just that variable of tolerability. If you have, joint compression and other things, it's not like it permanently pushes the jaw back. The lower jaw is a posturally movable bone. So you're not going to necessarily have permanent, like, oh my gosh, like I'm pushing the jaw, this is somehow bad. But it's just positionally, of course, you are having to brace against it.
Comfortable sleeping with it.
Can be uncomfortable sleeping, with it.
It shouldn't get worn down on the forehead.
Yeah, absolutely. So you
Now, question for you is, I know we saw when Facegenics was kind of designing this, that heat map that showed where the forces were versus on the side with the hooks on the teeth versus the bone anchorage. Can you kind of explain why that bone anchored protraction versus the current methods of, I guess,
totally. Yeah, well, I think, bone anchored protraction, especially if the protraction apparatus is, of course, in the case of, and just to kind of answer, on a point that we were mentioning earlier, like what have we seen with it? Of course, we don't consider facial protraction to necessarily be predictable in adults, but we do have seen a lot of cases where it is
We
successful.
got 2 millimeters on my one patient.
Yep, who's about
30, mid 30s, upper 30s.
Yeah.
We got 2 millimeters in about 9 to 12 months
Mm-hmm.
for protraction.
Yeah.
Yeah, he was a full class 3 underbite.
Yep.
And we jumped
Mm.
the bite with protraction expansion,
Correct.
which is a big deal at that age.
Big deal.
Yeah, we've done that with
And that's
20-year-old
standard,
Yeah,
standard rudimentary mechanisms, rubber bands, chin tuck face masks. Of course, we have some patients that a lot of the viewers of this podcast will know about who've gotten a little more than that. We have, we do see it work. And even if those gains are marginal, what are marginal gains really in the world of what we're talking about? We're talking about nerves, we're talking about blood vessels, we're talking about structures that are only fractions of millimeters thick or whatnot. We're talking about maybe 1 millimeter of anterior posterior depth increase, amounting to a cubic volume gain in a 3-dimensional structure, right? So these are all very important points to think about, right? If you've given the tongue a little more room, for example, then the tongue doesn't deflect the soft palate back as much. If that same soft palate, hard palate complex has moved 1 millimeter, now you're talking about, actually then, reducing the probability of airway obstruction. You know what I mean? So all these things,
they're cumulative and and a little bit can go a long way.
And what's kind of becoming almost like a buzzword in, me talking to patients is this idea that, a lot of patients come to us because of an aggregation of small problems or minor problems or problems that in themselves in a vacuum don't look that clinically significant. You start adding up a lot of these things, then you have, a problem. You have upper airway resistance syndrome. You have sleep apnea. You have, fragmented sleep. You have maybe sleep study results that look kind of, equivocal, right? And then you show up, to one of our offices and it's like, now we start identifying a bunch of little stuff that, come together to create a wellness problem. So why isn't it that then we can maybe undo a lot of those things just a little bit and start a positive wellness snowball, so to speak?
Yeah, the opposite.
Yeah,
Small,
exactly.
bunch of small things can create big result too. Actually, while we're at the protraction, well, you want to talk about that one case where we came up with our version of Bollard plates?
Yes,
That was kind of cool.
that was kind of cool. Yeah, so we had a patient who I give actually all credit to the patient in this particular case. Really, our credit only is in the willingness to explore what that patient put in front of us.
And I mean, all our patients. So we thank all of our patients for trusting us and then also always giving us great ideas and helping us improve, opening up our minds. So thank you to our patients. But yeah, go back.
100%. Yeah. So, we had this idea, I have a patient who's very interested in maximizing midfacial protraction for, what is, a pretty deep-seated belief that, of course, underdevelopment and retrusion of the midface has a lot to do with some of the clinical problems that we're having. So, of course, expansion is one medium to get nominal amounts of protraction. Then, of course, pulling from the expander medium, whether it's an FME or a MARPE, is another way. of getting some improvement. And of course, there are other places to put anchorage, and those things all have some pros and cons. There's a lot of mixed reviews out there on just, pulling purely off of Bollard plates. But generally, we see that sort of be a toss-up. It's another place to put some anchorage if you don't have any other reliable.
So how was the one that we came up with the patient different than?
Yeah. Well, so Bollard plates, by definition, right, they are surgical plates that are submucosal, right? They go under the gum, under the soft tissue, vestibularly, right? So you're opening up a flap, you're accessing,
Generally, that's demand.
structure.
You have to. An oral surgeon does that in the hospital or general anesthesia.
Exactly.
Yeah,
Right.
it's a pretty intense. It's a surgical procedure.
It's an intense surgical procedure, and of course, because it involves flaps and incisions and other things, we also have increased risk of infections, this, that, whatever, right? Of course, in the world of 3D guided stuff, right? I mean, of course, bone anchored expansion is what we call transmucosal, right? Where we're putting something in through, that's outside the skin, outside the mucosa, outside the gum, right? And then screwing through it. Of course, it makes the external apparatus more manageable, reduces your risk of subperiosteal or under the gum infection and things like that. So we made a transmucosal Bollard plate with the help of Partners Lab, who was very, again, and shout out to Partners Lab too for, some of the creativity in building some of these other things, for us, because basically the patient had this idea that, hey, well, teeth are anchorage too, and obviously we don't want to pull on teeth without pulling on anything else. But hey, what if we could, tie a couple teeth together, right? And also perhaps attach to it rigidly a TAD supported mechanism on high up in the buccal aspect. And to do that, we had to of course get really good vestibular impression of the soft tissue, overlay that on the CBCT. Tried
An STL file, yeah.
STL file, right? And you're really threading the needle between some roots to get sort of your lower anchorage, and then of course higher up, you just need to capture enough, so that the plate is going to actually conform and not impinge on the soft tissue. There has to be a little bit of clearance, and all of that seemed to kind of go pretty well. As far as just the planning and all that. So that's an example of a design that we had done just as a creative.
So that's why we're the people's orthodontists. We actually listen to our patients, and a lot of our patients are very, very, very intelligent, and they know the field, and so we actually rely to work on their cases with their mastering their own
Absolutely.
in their own anatomy and physiology.
100%. And the thought that you put into your own stuff often will make you a expert of that particular discipline, and so that's kind of why we do that. And but yeah, I think as long as we find a rationale to do that, we're not, our job is really to make sure that those types of things are safe and effective.
Vet it out.
Have some foundational basis, scientific basis for actually.
You want to give us an update about FME 4.5?
Yeah, FME 4.5. So, FME has gone through a few different generations or iterations in its improvement. We basically have.
So we've delivered what? 100? Do you think we've delivered so far?
We've got 55.
Yeah, between 50, around 50-ish.
50.
Yeah, 50-ish. Yeah. And we started, last July? And about 10 months later, we've done about 50-ish.
No, it started last February.
That's February.
But then it was until April, late March, then the second one, and then
Sure. Okay.
then it kind of started
Snowballing a little bit. Yeah, that's right.
Yeah. So yeah, anyways, we're somewhere up there now, and of course, all of those deliveries to date have been what we call the 3.5, which is essentially the iPhone 3, right? The second iPhone that came out. Of course, the first one, there were a handful of those that were installed by other doctors, as part of real piloting of FME. And then I think we've, all, pretty much done, probably 80-90% of the rest of the FMEs that have been done. And all of those have been the second generation, or FME 3.5. Of course, even that 3.5 has undergone, and just its little things about its process and end to end, kind of experience.
So small changes,
Small changes have been possible within the 3.5.
like rounding out the edges and things.
Exactly.
Yeah. And those are real time. So as soon as we deliver one, we talk to lab, Facegenics,
Yeah.
give them the feedback, and then literally they would implement that almost on the next one.
Correct.
Yeah.
Yeah.
Which is really cool, by the way.
Which is also part of, the inspiration for a lot of what ended up just being the 4.5. And the 4.5, I would say some of the main features are these, right? You have mediolaterally oblique TADs in the front 2 rows. This really maximizes bone anchorage just through getting, a little bit of a diagonal, and then also providing a direct, I guess, counter force to the tendency of the expander to do this, right? If you have screws that do this, you are bracing against that, possibility. Of course, that, has classically been one of the things that we touted as an advantage for the custom MARPE, and one of the reasons why we see custom MARPEs be pretty efficient and effective with expansion. So, to see that, what I mean, kind of coming to light with FME, I think is great. There's the mechanical component of that, and then there's also the anatomic component of that. We've had some patients that, because of, if you think about the nasal septal base, right, as like a little, sort of creak or something, right? Of course, most of the time in a normal, perfectly straight case, that's going to be straight, right? You're walking anterior, posterior, it's straight. So if you have 2 axes of screws, they're on either side of that straight path, and you're good, right? But in some cases, right, we have some deviation, some serpentine kind of course for that septal base. So we find that we have more flexibility, being able to position that without having septal engagement. Septal engagement has been the cause of a couple of the failures that we've experienced with FME so far.
And some of the ones that we're helping other doctors resolve their failures too.
That's correct. And so yeah, that's pretty much you. That is, yeah. So definitely to consider septal, I guess, deviation in architecture. Not, of course, in the traditional sense where you're looking at the nose coronally and seeing deviation, but we're looking at axially and seeing deviation at the base of its attachment. It really helps overcome a lot of problems there. And of course, with custom MARPE, you can put a screw here, you can put a screw there, you can avoid it at will. This is now given pretty much the same degree of freedom, for basically being able to position an FME without septal infringement, right? And then, or I should say encroachment, I think that would be a better term. But and so I think
And the screws, I guess, by default are going to be a little bit further apart too.
the screws are going to be a little further apart. The tails of the screws are going to be further apart, of course, in the front 2 rows.
So we're excited about that too.
Very excited about that. The next major improvement, I think, mechanically for the FME 4.5 is the diameter of the jack screw.
Yep. And that's
what the jack screw being, I think, a full millimeter thicker is going to give it a lot of resistance because, of course, when an FME sort of stops out, torques out, it's because there's so much, sort of flexure, tension in the system. Of course, the jack screw being able to bend to that system will increase the chance of failure. The jack screw's resistance to that will confer some resistance to the whole system against it doing that. So that is gonna, again, that's one of those things where 1 millimeter increase in diameter will result in a, globally, more scaled stability of the whole structure. Of course, we've looked at those custom MARPE barrels.
the tiger screws are massive.
Tiger screws massive.
Yeah, right.
So that'll be an upgrade. We also have a huge ergonomic improvement with FME. I think as a user myself, and we've had a couple others that, struggled quite a bit with some of the angular aspects of the back part of some of the FMEs, especially the protraction capable ones. We have what is now an increased radius of the edge. And what that basically means is that we have more rounded edge rather than a sharp 0 radius. And of course, it was never 0. But now, if you increase the radius of the edge, you're going to have a more rounded corner that will make for tremendously better patient experience in our view. And then we have what's called reverse taper. So if we have a posterior row, that is going to sort of flex up towards the soft palate, just so that there's not as much vertical bulk. Of course, we find it, somewhat distracting for the tongue. So I kind of keep banging on the back of the FME. And so again, huge, and we all adapt to it. So we're fine. That hasn't really bothered me in a while, but it's there, and you'll always notice that it's there. So it'd be nice if it was just there less the whole time, right? And then you have the lid, which basically what the lid is that the FME expander module, of course, nests into the anchor bodies, flush with the flanges of the anchor bodies, so that you basically have, you have like basically vertical support on the top, and you have side support. With a lid, you have a little bit of bottom support, and of course, the whole thing's screwed in, so there's
More dimensions of stability.
more dimensions of stability. And I think a really major improvement is, of course, the architecture and the taper of the anchor bodies itself. There's going to be a little more aggressive taper. We're going to, of course, be able to, really originally this was going to be called the vaulted FME. It just happened to include all these other improvements, and then just kind of loop that all together and call it the 4.5. It was going to be just a vaulted version you could order, but it's like, hey, let's
Build in all these improvements into it.
build in all the improvements at once. So the vaulted architecture, of course, helps the FME nest better into, narrower palates. Again, another aspect that we think is responsible perhaps for some of our less, successful results with FME. So I think being able to really nest that in there. And then, of course, in a expansion system where you depend on the tails of the expander, the tails of the TADs in the expander to produce and transfer the force to split an actual, mass like the, midface, those tails have to be part of a neck of a screw that's braced pretty nicely. Yeah. Of course, if you just have, you can lock in the TADs into the head of the expander all.
They're sitting on stilts really high.
Sitting on stilts, right? So now the necks of the screws have better bracing. And of course, the whole system can be nested in the palate in a way that really reduces our sort of air gap coefficient, which I think is responsible for, some underperformance. So I think that this is going to, again, be a huge
Improvement.
Improvement.
On something that's already pretty good.
Oh, heck yeah.
Yeah. We've had so many great results so far.
Absolutely.
Yeah. We'll put out some of the before and after CBCT soon too, more than we already had. So I'll look out for that. Let's pause right now. It's 3:05.
Yeah. I think it was a great start.
This is a great start. I agree. Yeah, we gotta stop right now anyways, because you gotta go to Sweetboro, we gotta go to Norwood. But yeah. All right, cool. Yeah, Bailey, you ready to go? Everything good? All right. So next topic.
Yeah.
Research studies.
Research study. Yeah, you want to tell us a little bit? I know you've been kind of spearheading the collaboration on the medical side of the research. So
we're actually really excited about it. We've been working. I wouldn't call it a research study right now. It's called a longitudinal outcomes assessment. There's some technicalities with institutional review board and how we get approval before and or after the actual data collection. So basically we're going to be doing, for all intents and purposes, a research study, but all of our patients that are going to get expansion are going to be getting some measurement outcomes. So pre-expansion, we're going to look at home sleep apnea tests that we'll be providing to our patients. Also we're going to be taking their blood pressure, blood sugar, and a bunch of measurements, including BMI, lung capacity and expiration force, etc. and then we're going to be doing some radiological measurements with the CBCT, see how much expansion they get. And so we're going to be comparing before, during, and after expansion, what kind of benefits the patient get. I think that right now there isn't too much current literature on MARPE and FME. And so a lot of the older literature is the MST2, and that was several years ago. So in the process, we're going to be doing a literature review as well. So we look out for that. And yeah, then we plan on publishing at some point, seeing what kind of outcomes our patients get from expansion.
Excellent.
Kind of bringing it more from just dentistry, because a lot of our patients, we can justify their expansion through orthodontic rationale, TMJ rationale, and we see patients benefit AHI, but there isn't much data on it, even though we see it. So now we're trying to put some data behind it, bring in more to your medical realm.
Yeah.
So we're really excited about that.
So tell us a little bit about, I guess, some of the collaborators you have, because I think, what you've just established is that, of course, we have some primary, occlusal and airway focused, structural, objectives with our treatments, but that there may be layers we don't necessarily know to look for, and perhaps ways that expansion may or may not affect other health metrics and variables. So tell us a little bit about, some of the collaborators.
Yeah, absolutely. So Dr. Ali, he's a professor at UCLA. He's a cardiologist, very, very established, has done a lot of clinical outcomes research studies. And so he uses his most current type of research studies incorporate a lot of AI algorithms. And so what we're collaborating with them, so he's going to be kind of helping us design the study and helping us implement it. So cardiologists are very interested in what we have to do, because if there's even a small decrease in blood pressure can have significant benefits to the patient's longevity and mortality outcomes. So if we can improve their health in terms of blood pressure, cardiological, cardiovascular outcomes, it's significant to the benefit of the health system itself and also obviously the patient.
And do we have basis, I guess, in the existing, medical literature or understanding to think that perhaps improvements in sleep and oxygen might, modulate blood pressure?
Yeah, 100%. So I think that having sleep apnea affects the heart, affects blood pressure. There's proteins in the heart that when a patient has sleep apnea are higher, that could indicate heart health. And so that's just one component. Obviously, if you're not getting enough oxygen to your entire body, that's detrimental. Sleep apnea directly affects cardiovascular health. And so, when a cardiologist or a health practitioner like that is looking at the benefits, they're looking at it for the longevity of their patients and what is applicable. So, we know that CPAP compliance is pretty abysmal. Long term, most people don't really like to wear it, and even if they do wear it, they'll wear it for too long. So if there's a permanent solution that's relatively straightforward for us, right? We do so many, and you could solve or treat, at least decrease your AHI. I mean, that's how a cardiologist would benefit from it. We're also working with our colleague who's pulmonary critical care. So he's they're interested in how, because a lot of their patients have CPAPs. Once again, they're not that compliant. So for them, they're like, all right, well, what's a better alternative that's permanent, that doesn't require compliancy? Dr. Mahmoud. So we're very excited about that. And it's at some point we were collaborating with an ENT, pediatric ENT. Right now in the design phase of our study, we kind of dropped off a little bit, but we intend at some point to do multiple rounds and versions of different studies. And so we're definitely going to incorporate, once again, the children's ENT, see how this could benefit AHI in a child and things like that.
So And how about the inclusion criteria? Is there a particular protocol that we might use to either select a patient for initial screening and thereby kind of qualify them for data collection? Like what are some of the qualifiers for the patients, or some of the demographics or range of, age and that kind of thing that we're looking for?
This is a very great question. Right now our study is funded by ourselves, so there's a cost. So all of our patients that are engaging in expansion are automatically included, if they so choose. And
Adult patients, pediatric,
right now it's adult.
Adult.
Yeah. Adult expansion, bone anchored expansion patients
bone anchored expansion.
with either MARPE,
Yeah.
custom MARPE, or FME.
And then have we as a group identified any exclusion criteria? I mean, I know that there's going to be, and this brings up a very interesting point about the biostatistics part of things. I understand that Dr. Ali is a expert in biostatistics. Where, maybe things that typically would be exclusion criteria, maybe is it now a direction in research in general, and maybe for our project, that maybe these things can be sifted out by the algorithms? Like, let's say, maybe the algorithm is able to, I guess, account for different variables if a patient has a comorbid health condition. Of course, many of our patients don't particularly have a lot of those things, but I know that you've been in more of the meetings, with the team. Is the direction on biostatistics just that, hey, AI is going to figure out a lot of variables for us, or are there, like, how do we, I guess, tailor or leverage AI to our advantage in trying to answer some of these questions?
Fantastic question. So Dr. Mati, he's obviously a physician, but he's also doing epidemiology and research. So the combination of our physician cohort is very, very intelligent, and they also know how to conduct studies. So Dr. Ali has done a lot of studies with AI modeling. Not only is he a very accomplished cardiologist physician, but he's also very good at programming and figuring out how to create Apnea algorithms. And so basically the way once we do the data collection, he'll run it through AI algorithms and see where the data points aggregate, and then basically almost reverse engineer what the hypothesis and what you get data points in, let's say, a cluster, and then you basically figure out why that happened and how that happened.
Probably the ability to do that depends on tools that he's either aware of or has developed that
And he's used, correct.
is not.
Yeah. Well, it's basically, and I've seen some of the data plus that he's done on his existing studies.
Yeah.
And you'll get, like, literally, they'll run different algorithmic models like once, and then do like another like sifting of it, and then where the data points come up on a plot to basically, all right, why did this happen, and then they kind of go backwards to what created that. So the beauty of this is, typically before this whole AI, we would kind of come up with a hypothesis and then see if it was worthy of study, and then figure out if the study kind of proved it or disproved it. In this circumstance, we take the data, and then whatever plots and whatever we get, then we come up with what that meant. So you get a lot more out of your actual studies in your data collection.
Perhaps more than you need to look for.
Correct.
Yeah.
So which is very exciting. So some of the things that, obviously as a neuroradiologist, we're going to be taking a lot of these measurements of the BMI, blood sugar, blood pressure, et cetera. Then we take a lot of the measurements
From the
imaging, seeing what sticks out.
Correct. So we're gonna have quantifiable metrics, that are measurable. Of course, our outcomes assessment in our field, is largely, kind of this quantitative, kind of thing. Of course, you got your sleep metrics, changes, and then we have our imaging changes. Oh, how much expansion did we get? How much nasal volume increase did we get? How much intramolar? How much nasal base? How much nasal cavity? Was there any anterior component to the expansion? And are all of those variables tied to the outcomes.
Correct.
Right.
And the more data we put in, to the extent, because then we can run another algorithm, but the more data we put in, the more
Yeah.
stuff we can find out.
Yeah.
And then our goal at some point is to essentially come up with, with this information is to say, hey, what if we expand X amount of millimeters, we can decrease your possible AHI by X. That's one of our, objectives long term.
So, and the way I see it is, perhaps we're going to have patients included in this study by kind of two channels. There's one group, I guess, that's, conventional, expansion patients seeking our services. And they're going to, perhaps be included in the study with their, consent. And then it sounds like perhaps maybe there's a group of people out there who may be interested to participate. Let's focus first on that group. If you're a patient out there, watching this podcast, you're like, what, it would be interesting to contribute to the understanding here. This might be an opportunity for me to treat, some of the conditions that I've been, wanting to treat. And it may be an opportunity to, of course, better understand quantitatively where I stand and how this may or may not have helped me. So what are kind of the steps for a patient who might be interested to participate in a research study?
So there's obviously, as we know, with current NIH funding and funding that comes from federal government, it's very expensive to do research, is the bottom line. And so the fact that we are literally funding the whole project, there's obviously some limitations. This is more of like a pilot study. So the goal is once we come out with our first, paper or two, if we can actually get funding from outside resources, that'd be great. So right now, I'd say our main focus is our existing patients that are looking forward with expansion. Now, once again, if you are a patient that needs expansion, then definitely come in and, we'll do a consult for you. And if you qualify, then that's kind of built in, we're including that for all of our patients.
And so now let's say we're either a new patient of ours or an existing patient who hasn't yet started, who we can do some of this initial data collection on. What happens, I guess, before their first appointment, and what are we doing at the records visit? And this is, I guess, practical guidance for, of course, what to expect at your first appointment. Yes. Is conventionally we take, of course, our standard photos and x-rays and things like that. What additional things and how much additional time might?
Yeah, this is a great question. So let's say you're a brand new patient that heard about coming to our office. An in-person consultation includes a CBCT, hopefully a large field of view CBCT, including DMJ and Airway. We take an iTero scan, take a 3D STL file scan, take our photos. And obviously, we do a consult with yourself or myself. Then we go over all their, symptoms, signs, conditions, etc. As they move forward with the treatment, if they need expansion, then we automatically, at that point, if regardless if they're at a sleep study or not, to be able to normalize and make sure it's consistent, you get a Watchpat from us before the delivery of your expander. Then the day of the expander, we would prefer that before you ate or drank anything, we would take your vitals and all your measurements. I would say time to take that additional information, time of the appointment, is probably less than 20 minutes.
Yeah. And it sounds like it would be best if that were a separate appointment from the initial consult or records, right?
The data collection. The data collection for the research is the day of the expected delivery, so that I'm making 2 visits for blood pressure.
Okay.
Right, we're gonna prick your finger.
So perhaps a little additional time on the front end.
Yeah, minimal.
Yeah.
Okay. Yeah. And then so we want consistency. So the goal is to take that in the morning of your expander delivery. So if you have an afternoon appointment, we'll select FMA, come in early, take your records, and go your breakfast where we need to come back.
What about the timing of giving the patient the Watchpat the whole sleep?
Yeah, so we could do that a couple weeks in advance.
Couple weeks.
Yeah, up to a couple weeks.
And are we? Do we have a target number of nights of data that we're looking, or just one, or is
So definitely pre-expansion. Then we're gonna do post-expansion. So when we tell the patient to stop turning, then we'll take another CBCT, take another Watchpat. Then there'll be post-orthodontics.
and the pre-treatment, is that just going to be one night of data, or Watchpat one only record one night of data, or it's disposable of? Okay.
So disposable, they say 1 night.
They say one.
Yeah, and I think you can only do 1 night.
Technically capable.
I'm sure it is, but that's how they make their money.
I see. And
But let's just say you're a patient and you don't know if you have sleep apnea or you have an RDI. You can still ask us for a Watchpat, and we can still provide a Watchpat for you. And then we can also get that read by a sleep physician for you.
But let's say you're a patient of ours, right? You got your Watchpat, you know, kind of done your pre-bedtime routine, you put the thing on, right? You think you're in the gear of, you know, kind of reporting your data, but then maybe something anomalous happens, like, you know, I don't know, construction next door, or like ambulance or something, I don't know, some weird stuff. Is there like, that's kind of part of why I was asking. There's
I don't know that. Actually, this is
I know it's oddly specific.
No, look,
These are the things I worry about, right?
Well, if you're living in a city or something, I mean, stuff like that could happen.
Yeah.
I think that we'd have to talk to us and watch that and see.
Yeah.
But I don't know that answer.
Okay. Yeah. Or to at least, let's say a patient.
Yeah, I mean, I wouldn't say.
Let's say a patient tells us that they don't feel that the data was very representative, right? Because that initial data, you can never get it again, right? So if they feel the data wasn't maybe representative of what a normal night's sleep was like, for whatever reason, you know, is there, I mean, I guess.
Yeah, on our end.
Procure another.
Yeah, on our end, we would definitely make sure we get the right data.
Yeah.
Because pre-data, you can never get it back. So I tell all of our staff, all of our patients, pre-information can never come back.
Correct.
Ever.
Yeah.
So that's the most important.
Yeah.
So we will do whatever it takes to make sure that it's good.
Yeah.
If that makes any sense.
Yeah, it sure does.
And I tell our staff all the time.
Yeah.
Post photos, you can always literally do. You can never go back in time. So you always want to make sure those pre-photos are really good.
Yeah.
And pre-data, obviously.
Mm.
Yeah. So we're very excited about that. So that this is a pilot study, and then the goal is once, you know, we get some preliminary data, maybe, you know, do some abstracts for medical conferences, you know, hard, you know, pulmonary critical care type of conferences, internal med, and sleep, obviously. Because, you know, we see the potential health benefits, not just the dental component benefits, right? So if we're, you know, promoting this and touting how great this service is, we need to have more medically related data. So that's kind of my, you know, our life. I mean, for me, for sure, you know, still help the world breathe a little better. I mean, I think that this is, you know, a good step in the right direction.
Absolutely. And, you know, and this may be a little bit of a left field question, but, you know, what do we, is rhinomanometry something that's easily measurable? Like what's, I guess, you know, because it seems like useful data, to understand, you know, and quantifying basal, you know, breathing and airflow. Is there a place for that in this study? Is it beyond perhaps the scope of this study? What do we think?
So, you know, that's a great question, because there's some dental sleep groups that really tout that. And I was trained by the DSM and, you know, diploma, the ABDSM, and that's something that was not completely, because I think that it's still a little bit, it's not concrete and certain with how it affects sleep and OSA. And so we kind of did not focus on that component. But it's definitely something that in the future for future studies we can kind of add more stuff. In addition, I mean, at some point we do plan on using the ray face ray scanner. We just got that hot off of the UPS truck. Thank you, Bailey. So we will be implementing components of that as well, sir. So now our records appointment will also include a ray face scan. And it also basically, what is that? It's a 3D scan of your face. So we have vestigial file of your occlusion of your teeth and your palate. We have the CBCT. Then now we have a 3D face scan too. So it was to see how expansion affects the actual component as well.
Yeah, excellent.
And we'll even how to predict what the patient could look like.
Correct. Well, and I think that's a big big one, because most of us expansion providers, so to speak, we speak in terms of generalities, and our patients ask us questions about
How's it gonna look?
how it's going to look and all.
If I know it's gonna be,
I think we mostly all kind of say the same general types of things. So I do think it's very valuable that we might be maybe studying that in a little more granular fashion. I guess there's no way to do that unless we have surface mapping data of the face.
so we're very excited about that.
Yeah, excellent. And then, of course, to compound that data with other metrics like, BMI, weight, this, that, of course, we can then, account for some of those variables as well. Right. Of course, there's no way to account for all variables, right? You might, be on a little bit, more water retention one day than the next day or whatever. But generally speaking, I think, but that's where then you have the volumetric, sort of data set of the structure underneath, right? The bone, and those changes absolutely, would, let's say if changes there correlate with facial changes, then we know that there's a very direct link, and it's not necessarily attributable to other external factors like weight fluctuation, water, anesthesia, and so forth. Very good.
Yeah, we're very
So that's very, very exciting.
Yeah, we were working on it probably for the past 10 months.
Yeah.
10 months?
Yeah.
Yeah, so, we're basically ready to start, like run out. Run out.
Yeah. No, and I think it's, you've of course been a bit more active behind the scenes in, and meeting with the group. And
Well, if anybody does research, I mean, it takes
yeah.
forever to do, because, there's so many T's, and you have to cross so many I's, and you have to dot. And so not everybody needs to be at the forefront at every step of the research. So, I know that you're going to be doing a lot of back-end work with the CBCT measurements.
Well, we may.
So if anybody's a really good...
saw the help of some of our.
Yeah, so actually that is a goal. So matter if any patients are prolific at measurement of CBCTs, and some of them know who they are, please reach out to us. We would love to calibrate with Dr. Newaz, so that we're all looking at the same scan in the same ways, and you can actually help participate in the study as well, helping behind the scenes.
Yeah.
That is very, very, very important. And I want all our patients.
Oh, go ahead.
I want all of our patients to know that we think that we're genuinely trying to expand the health.
No pun intended.
Like, no pun intended. Trying to make the world a healthier place, and so every patient is a part of our mission. So we thank all of our patients, and
Yeah, and a quick shout out to Dr. Lasada Lisbeth, who's going to be, she's going to be, she's an up-and-coming dentist from UPenn.
and Alex Bailey. We've done a lot of back-end work, so Alex, a pretty good honor, and obviously Jawley. Thank you, Bailey.
Boys, thank you guys.
Switching gears, we're definitely always trying to, I don't want to say expand again, because that's actually what I was going to say, but we're trying to increase our continuing education, because you got to always be abreast and learn more and eat better.
Yep, absolutely.
So are you taking any relevant continuing education courses?
Yeah, I think, one area where I've really wanted to up my game a little bit is in of course, as a radiologist, it's always, a little bit, I guess it's always felt like a little bit of a gather in knowledge, not to have a really firm grasp on MRI interpretation. Now, of course, as a, maxillofacial radiologist, there are some basics of, dental TMJ MR interpretation that I am familiar with, but, by no means to the level of proficiency where I can just, kind of jump right in there and, give the formal interpretation. I'd love to get to the point where I think that would be the case. So I did receive, just from a listserv, I got an email blast about, a continuing education course at the University of Minnesota. And so I'm looking forward to going there, and, they have some really good people over there, well known in the field, who are going to be launching that class. And I think it's a great opportunity for people like myself to, gain a level of, proficiency. And, I do see a world where, perhaps, especially in this world where we're collaborating with a lot of surgeons who are studying, and, typically us dentists and specialists, we rely on the interpretation of the musculoskeletal radiologist that's, on staff, reading the MR, for our open and closed TMJ exams, that the oral surgeon, for example, might order to assess soft tissue changes, internal derangement, other things in the joint, to also prepare and planning for joint replacement, or assessing the appropriateness of joint replacement, and things like that. Of course, a problem that we encounter, pretty much, pretty frequently.
Yeah.
And so, I feel that I would love to have the opportunity to, of course, play a stronger role in that diagnostic, process. And wouldn't it make a lot more sense if those interpretations in part came from, people like us who might be able to also maybe embellish a little bit more color on this structure that we deal with on an everyday basis in real life, right?
Now, so to kind of just reinterpret what you just said, if, let's say, you're an oral surgeon, you're asking for an MRI, who's reading that MRI?
It's the MD musculoskeletal radiologist.
So they don't really specialize in the TMJ or the mouth. So for them, it's just generic, and they can't put a lot of puzzle pieces together that somebody like yourself could potentially do.
Perhaps by volume they happen to, and they gain some proficiency. I mean, I've seen some wonderful reports come out of some MD radiologists that show an impressive level of knowledge and understanding of the joint. But it's never just going to kind of quite be what we would have otherwise clinically. It's kind of like there's this gap between what they can do radiologically and what we know clinically. And if there was, a way to bridge that gap, I think it would produce a lot more robust interpretation reports for these things. And of course, the very limited number of institutions do have, maybe like a head and neck MR team with, either an oral maxillofacial radiologist or a neuroradiologist or a musculoskeletal radiologist that has, very in-depth understanding of the topic. But of course, those people are, kind of like other aspects of our profession, just kind of like, hidden gems. Yeah, right. Typically, right, you kind of go somewhere and you order an open close exam of an MRI, you're not necessarily going to get that level of proficiency, understanding, and detail.
So do you think that it would be advisable for oral surgeons that do TJRs, for example, to go to an oral radiologist like yourself that's, let's say, proficient in MR to give an interpretation, because then they can use your intellect and your interpretation to help their judgment of procedure?
Well, hopefully what I, inshallah, will be. But, as far as like, but yes, there are colleagues of mine in the OMR space that already have that level of proficiency, and they might be able to be a resource when their services are not necessarily sought or are relatively hidden or lesser known. So, I think, I mean, I seek for a future where, maxillofacial radiologists do have a little bit more of a seat at the table of these types of things. And I think that, that's, it's a little bit, I think, I think there's a little bit of that, happening. But obviously, we would like to establish a model where, we have a very all-encompassing team of capable professionals. And one of the services that a team like ours could offer is really robust interpretation support. And, foreshadowing a little bit into the future, I see myself maybe playing a little bit, more direct role in that arena, because I think that's a lot, where the value is. And this is also, good segue to talk about, that I think we're trying to basically build with our network of offices, which we can talk about how that's been evolving. But, we're trying to build, I guess a model of healthcare delivery where you don't just necessarily have one set of eyes looking at the case at any time, right? You have the field person, really looking at and running your case. But then you maybe have a background set of eyes, also looking at your case, and you have multiple disciplines, levels of expertise, looking at your case. And I think that's really what we seek to build. And so, I can see a world where, maybe a couple of years from now, my primary role in that team is more of that sort of quarterback, behind the scenes and interpretation, the second set of eyes on the case at all times. It's hard to do that when you are in the field. Yeah. Running around from patient to patient, seeing, a bunch of patients all the time. Yeah. In the field, then you can't be sort of the house diagnostician. And I think for a patient to be able to have the services, the hands-on services of a really good field clinician and a really good house diagnostician, I think is the rule of healthcare.
Yeah, and then that's a important distinction that you're making, because majority of orthodontists or dentists, they're doing both, and so you're limited to the brain power to one person, versus if you have a multi or interdisciplinary team in the background that's reviewing the cases and coming up with different solutions. Now you can open up your parachute of ideas, and then the implementing clinician can take all of that data information and actually implement the best path there.
Absolutely.
And I think that that's one of the benefits of us working together. I mean, you're obviously a double specialist, and then with the a lot of cases that I'm done as general dentist, whether it's the implantology, dental sleep medicine, cosmetics, building the vertical. Those are things that when we collaborate, I think our patients get a different level of service that they normally wouldn't be able to get.
That's our intention. Yeah. Yeah, I mean, we're really hoping to, because I think what we can all appreciate, all of us in this space, providers and patients alike, I think we understand that there's a greater level of complexity and need, and, tracking and following, and, hey, what, outcomes assessing, and being able to make real-time decisions about, something as, routine as, okay, an arch wire chain there, Invisalign code fall, or something like, should I continue expanding or not? And to sometimes make those decisions on the fly when you've got, bullets coming at you from 50 different directions.
I was asking him,
Yeah, exactly. So I think we know that there's a need for a greater level of, participation. And I think the model that we're contemplating is the model to achieve that. And so I think patients will be able to, really be, concierged into true wellness.
And then this also goes back to the research study and how we're trying to bridge the gap between US and dentistry. The goal is to collaborate with our medical doctors in these comprehensive treatments for, sleep apnea, etc.
Yeah.
I guess some courses that I'll be taking. I plan on doing some oral sedation. Right. Also, some of our patients that do have anxiety or are a little bit fearful of dentists, especially some of our large full mouth rehabilitation cases, to give them some twilight sedation where they're a little drowsy, and kind of keep it relatively mild and safe for now and less risky. Absolutely. That's one thing we're doing. We're planning on doing the tongue tie course. So although I already use a laser, I've been using a laser for quite some many years, but we want to increase our in portfolio in tongue tie for infants.
Yeah.
Tongue and lip tie release. Yeah, so then
And as a father of a new infant, I'm sure you're studying that.
yeah, so actually she
on the tongue. And,
yeah, so she does not have a tongue tie, but I do believe that she had a little bit of a lip tie. And I'll show you that.
Yeah.
So we get out. Yeah, so that's something that put an implement can't put on child.
Yeah, absolutely.
So that's something pretty exciting. And then I think you took the Dr. Stephen Olmos course, right?
Yeah.
So I'm gonna be doing that one.
Yeah.
Can you kind of go over what you learned on that course?
Yeah, I mean, I think that's a great resource for, learning hands-on motor nerve reflex testing. At least that was the module that I completed. My former partner and, the person who started the whole Vermont office and really the brand, TMJ Sleep and Airway Orthodontics, she was a big, I guess she really understood, that world very well. And was very good at, utilizing different dimensions of motor nerve reflex testing. Of course, our body consists of a number of reflexes. We have, nerve pathways, all over the place, and there are ways that we can control for, turn on and or off, basically certain reflexes, and use different, I guess, ways to test the jaw as a variable, or, it's not just.
So how can that be practically applied? Right. So I mean, I'll argue, well, before you go into that, so we just did a consult on a patient, and I saw you do that. Obviously, continue to do it a lot of times, but we saw the stability that she had, literally when you instantly as soon as you put out, seemed secured her bite.
Yeah. I mean, decompression is decompression.
The MSC turned me to a D, but extra oxygen.
I think I'm experiencing a similar growth.
I'll join the club.
You have to, bro. I really thought you were going to.
No,
4.5?
within the next year, yeah.
4.5?
5.5.
We get my hair transplanted, get some bigger maxilla.
Oh shit!
Yeah.
Oh shit!
Some of that dad bod, You recording?
Yep. It's all good.
So let's move on to our offices and the future of Brandon.
Yeah. Well, I guess we've got a couple parallel brands. Of course, we have our we have Team Dental. You started Team Dental back in 2013, I believe, right?
12 years.
Yeah, and I was just graduating from dental school at that time, and and you started this brand, and I think that brand has some recognition in this Philadelphia region, and of course, now, we're at a point where you, as of maybe the last 5-7 years, have grown an awareness that, wow, part of this whole teamwork and dental and all of that, and delivering truly comprehensive care transcends beyond teeth and occlusion into airway and whole body health, jaw wellness and posture and balance and all that kind of stuff, right? And so of course, that affinity for that kind of work, coupled with the fact that we're, of course, long time friends and colleagues and
20
brothers and
years.
It's almost 20 years now, 19 years that I saw you give that presentation about how you rap to get admitted into dental school, and then of course, my journey has been, I kind of mostly worked in other offices the first few years of my career, and all of that, kind of pretty quickly evolved into me having my own offices. We're just kind of, winging it. We're not really that far beyond that point now. And, yeah, I'm thankful for where we are, where, essentially we have, a group of 3 offices, Vermont, New York, Florida, that kind of has this sort of specialty branding. We've got the Philly offices that primarily has the T dental branding. Of course, we're basically bringing, I think, both components, comprehensive dental care, with, sort of awareness and acknowledgement of all these, functional and airway kind of, aspects. And then, of course, actually delivering the specialty work in a specialty environment. I think that's something that we're, very happy to be, sort of, finding a way to merge and bring together and, sort of trickle into, each other's offices, so to speak, right? I'm kind of trickling into Philly. You've, of course, been coming to Vermont and all that. And, New York, we started together back in 2021. So really, we're I think we have a nice little footprint across the Eastern Seaboard to basically bring this, kind of model of dental and healthcare delivery to the people. And I think we're starting to get to the point where, we can bring on some other, talented professionals and have a system for, kind of getting people, with their unique flair and skill set onto the team and contribute. So I'm really looking forward to, I think a lot of this growth is really happening in front of our eyes. And it's humbling. It's a humbling journey, kind of trying to do all this just pretty much as a young kid trying to make it in America right now. But, we got a lot of bills. We got, we got a lot of.
I mean, I think that
but
I mean, our goal is to change the world by helping it breathe better.
yeah.
We got to breathe a little bit ourselves too. But in the meantime, while we're not on planes or driving a lot of hours, we are trying to make an impact. And I think that kind of alluding to what you're saying, I think that having the TMJ, so it's basically the specialty brand is going to be called TMJ Sleep Airway Orthodontics. That was originally, essentially the Vermont name, kind of. So that is airwayortho.com, right? So kind of keep it simple. But those are the specialties that if anybody was looking for a specialty type of procedure or service, then that's how they find us and our services on the Eastern Seaboard.
Yeah.
So we're really excited about that. Definitely a work in progress. And definitely need all of our patients' help to, show that we can actually help people's lives.
Absolutely. Yeah. No, and I think, what we really hope to be too is a place where you can go, get your routine, dental checkups and all that kind of stuff. And, because of course from that comes a conversation about, the possible, dot connections in the health between, what we see orally and, what we see otherwise health-wise. And if there are solutions inside or outside of our building that may just help the person get better. And of course, I have a particular, sort of passion for helping kids with this kind of stuff. Of course, being an orthodontist and being accustomed to treating younger people, I've, made myself comfortable with seeing, especially young people, we expand people, as early as 3 years old. And we might even evaluate them sooner than 3 years old just to kind of start that association of like, chew on this chew toy and this and that. Oh, let's look at this. Let's kind of, do what we can, between, sort of monitoring sleep, getting ENT evaluation for tonsils and adenoids, trying to kind of start making those, good habits, good dietary changes, this, that, whatever. And for the kids in particular, right? Like we want to be, I think, a network of offices where we're kind of like an orthodontic practice like anywhere else, where you happen to come in and, of course, have an experience where, you're getting professionals who, care about whole body health and airway. In addition to, like, sure, a lot of people just need corrective orthodontics. You come in, you get your teeth straight, but at least, whoever's looking at you and running your treatment is also
In the
looking at a lot of other things, right?
Health, whole body.
Exactly. Right. So it's like, that's kind of what we seek. And we do,
So just to piggyback, obviously, you treat adults and children. You may have a personal preference towards helping, kids. Why do you think that's? Why do you feel like that? Because I'm the opposite. I like treating more of the adult population.
Well, I think, we've gotten obviously really comfortable, treating both kids and adults. I have tremendous relationships with a lot of my adult patients. A lot of them, I respect their knowledge and participation in their treatment more than my own. So I've really grown as a result of that. I'll always, be sort of thankful for the opportunity to be in this seat, because of the privilege of having been able to participate in adults treatment, especially obviously when options, the work is harder to do, options are limited. People go around this sort of, they get the runaround from the healthcare system, and the buck stops with us, basically, right? And so of course that'll always hold a special place in my professional life and my heart. But I think for the kids, obviously the reason why we're running around as adults trying to find healthcare answers is because perhaps there are things that we could have done in the formative years to reduce the susceptibility of having certain of course health structural issues, sleep related breathing issues, so forth, right? Jaw and facial development related issues. We can't always, totally turn the tide on nature and genetics, but we can certainly do the best that we can within the constraints that we're working. And, to be able to take a part in that seems like, a more, I guess, monumental endeavor in transforming the health of our population.
Yeah.
I think if we can really get in and
Preventative for the population. If you can treat a child and prevent a lot of the issues that we see in our adult patients, then they have a lifetime of health and
correct.
Yeah.
And if we're looking to improve the world we live in, for the future, right? Just a lot of the healthcare system is taxed by, comorbid illnesses with, a lot of the conditions that we routinely treat. And so, of course, if that amount of tax is placed on the healthcare system, imagine if we had a shift in our profession towards acknowledging the importance and the role that we could potentially play in changing that tide for the next generation or two. That would actually have an impact, I think, on global health. I mean, that's my, belief at my core. And so anything I can do to play a part in that, I think is important. I think, and this, we hope to, be able to further push this to the public health level.
Correct.
That, hey, why are, public health related programs for kids maybe not, necessarily in acknowledging or covering things like expansion, unless you have like a unilateral crossbite. We have score X on your Medicaid treatment scoreboard, right? You know what I mean? Like, can we shift the tide on that as well? Can we have some power and influence over the system to change the system to make, these types of, protractive, expansive therapies accessible to people from all walks of life?
So if you are a patient that is in the public health arena or is interested with working with us in the future, definitely reach out to us, because this is something that we do want to bring on as a policy change, help kids breathe better, which in turn improves the generational outcomes for the world. So
Yeah.
let's see what else. We'll talk about our trip to Malaysia. We went there in February or in January, and then now. So you want to tell us how that went, and then what's the next step?
Well, it went well enough that maybe the next time I go, that'll be the last time I go. Maybe I won't come back. But no, I'm just playing.
So Malaysia is. Malaysia is a great place.
Malaysia is a great
We
place.
both loved it. All our families loved it. It's so if you have a chance to go to Malaysia, we definitely recommend. We were hosted by Dr. Firdaus, he's an oral surgeon. So we collaborated with him on our cases. So we thank him for that, and his staff and facility.
Yeah, no, he was a godsend to us. I think we, of course, at some of the lectures I used to give to the international groups at NYU. He was the main, I guess, steward of the, dentists that he would bring, and dentists and orthodontists that he would bring to, NYU to, kind of pick up, a few days of education just from, random experts in different areas. And so that's how I, kind of interface with the group initially. And of course, it's resulted in a relationship that's allowed us to, hopefully bring our services to other parts of the world and educate, local communities on running this kind of, work themselves and so forth. Because we, of course, get a lot of inquiries from around the world saying, hey, nobody in XYZ part of the world really does this. So what options do we have? And, but I really appreciate Malaysia as a society, as a, a very, it seems like a very inclusive, progressive society. And of course it's, and it's just a joy to be there. It's beautiful. It's,
And great food, by the way.
Oh, yeah.
The food is amazing.
fantastic.
So we were there end of January. We saw a few patients, delivered a couple expanders. We will be there the last week or second to last week of June. Then we're flying out 'cause the patients on June 24th, I believe.
How many installs did you guys do?
Two.
How many you got?
Two, and then we had a third that we basically did some kind of it was a patient in progress who's from that half of the world, so we were able to see them just for a progress check and do some little bit of adjustment, and
We had a second consult with another patient.
Mhm.
Yeah.
Yeah.
And well, that's something we could talk about in the future. Different empty nose syndrome and UARS and stuff like that.
Absolutely. Oh yeah.
But we'll be back in Malaysia,
Boxed on.
and that's another podcast. But we're back in Malaysia end of June. So if you are an international patient,
It's after that.
if you're a national patient and it's difficult to come to America, it's a little bit more challenging these days. So definitely reach out to us. Our staff, Runa and Amy, can help you with setting up a virtual consult. And
Even as a citizen, it might be difficult for me to return to it, but that's also a separate conversation. But
so now what's our next you want to talk about the Philadelphia Union?
yeah, buddy.
So we're the official dentists of the Philadelphia Union, which is the MLS soccer team in Philadelphia.
Well, tell us a little bit about, I guess, kind of what started that relationship, because it's certainly not a random, like, hey, random soccer game,
So the captain, Alejandro Bedoya Ale, whose birthday's today, by the way, happy birthday, Ale.
Happy birthday.
Watching this. So he came in and we did his Invisalign, and so he did Invisalign, and I mean, the back of our heads were like, how do we collaborate with some of the professional soccer teams or teams in general. And so it just happened, I got a phone call from the union and then I went into that. But I'd say more importantly, our goal is to bring health and oral awareness to athletes. And so we, I know that, for example, a lot of soccer players don't wear mouth guards. So that's definitely something that we need to address.
Yeah.
But we do see a lot of athletes, even famous athletes, that have airway issues, or celebrities, and we think that having more of those prominent people can also help change that tide, public health tide. Mouth taping is a big deal, and because certain celebrities do that, or they breathe the right scripts for the intake breathing to get more popular. So because of certain people doing it, it becomes more popular. And so we do feel like working with the team could potentially bring better athletic performance. Some of the mixed martial artists or boxers, etc., bring better performance, and also could yield and get better championships, etc., etc. So
Yeah, and I think what we're seeing too is that there's a whole opportunity out there for health maximalists to optimize their structure or function, of course, some of the work that we do is in service of those types of goals. So, we're no longer just in the realm of, basically trying to treat disease or trying to treat, susceptibility to disease. We're trying to health max. We're trying to, optimize performance, breathing, athletic performance, all that kind of stuff. And I'm not going to make any lofty claims about, that, oh, if you do so-and-so, this will improve your athletic performance. But I certainly can say that, we have seen a lot of reports from our patients that, hey, once you did so-and-so's treatment, particularly expansion, I'm able to breathe or run a mile breathing through my nose for the whole time.
No feels.
And I never used to be able to do that, right? It's the things like that, right? I have more energy. I have more, yeah, definitely. So
If I can call that bodybuilder, he said he was free after 7:30 tonight. Watch out. He was a bodybuilder, did MSc, he was on drugs, running through there, asking questions back for.
Let's circle back on that.
yeah,
Just the idea.
no, that's a really
That is a rig because I do. Let's make that an actual. Okay. Yeah, with the because I like that because I think that's huge, right? Now same thing, with the health maxing, we do collaborate with a lot of the PRI PTs. So what is PRI? Postural Restoration Institute. And so a lot of the physical therapists do further training. Can you kind of explain what PRI is, and how that and how we collaborate with PRI providers?
Yeah, I mean, PRI is, kind of I guess, it'll be difficult to really summarize this into, one line, but, essentially it's a school of thought, that takes into account, I think, a lot of interconnections in body systems, and trying to find neurologically neutral positions, for, kind of being in balance and, seeing that, hey, maybe the way my rib cage expands, this side or that side may be I mean, we're finding imbalances in the body, trying to address them, right? We're thinking about, what kind of shoes we're wearing. We're thinking about how that affects, the arches in our feet. We're thinking about, basically, our rib cage, our hips, our vision, right? And the vision stuff is particularly
Ringing
equals.
Yeah.
Yeah, I mean, just to know that, 20/20 vision isn't necessarily optimum for everybody, and that there are things that people should do before they seek permanent, corrective vision options.
Yep.
Like LASIK or, PRK and all that. That there are things to look at with respect to body posture, function, and balance and stability.
And there's shout out to Greg McLean, Project Airway.
Oh, yeah.
Definitely follow him.
Yeah.
He definitely talks a lot about this. Yeah, but we do collaborate with PRI trained physical therapists, and so when for example that patient that we saw today, the neuromuscular reflex testing, should be a prime candidate to collaborate with a PRI focused PT because a lot of the patients have hip issues and TMJ issues and they go from top to bottom. Yeah.
Right. And, it's, we're talking to patients about their feet on, Zoom calls. You know what I mean?
And I mean, it's like a lot of our patients, and when we ask those questions, they never heard about us or, it's a brand new patient. They're kind of taken aback, like, why are you so interested in, some of their, symptoms and things like that. And we kind of had to explain to them that the whole body is linked, from top to bottom, not from bottom to top.
Absolutely.
Yeah.
Yeah.
Anything else you want to talk about, Oliver?
Perhaps between the time we've spent podcast, the patients that we've seen today, I might be a little talked out, but what do you think? We all know our limits.
Yeah, I think we're I mean, you got to drive back now, and
Yeah, buddy.
we got to be awake for the day tonight.
Yeah.
So yeah, I mean, I think that we've had a lot to talk about.
Yeah.
We do plan on at some point meeting up with Ronnie again.
Oh, yeah.
Jax.
Yeah.
And so we're excited for that. Maybe do a 1-year review of FMEs that we place.
Yeah.
And then we are going to be placing an expander on my handsome son over here. Can you smile? Yeah. Okay, cool. Yeah. Thanks, doctor.
Yeah, buddy.
Yeah, buddy.
All right, Wilson. Thanks, guys, and Wesley travels back, and
Really here.
Yeah. Yeah.